Thank you for attending this lecture on new developments in cutaneous soft tissue pathology. I'm going to talk a few developments that I think you may find interesting. I'm going to turn off the camera so you can concentrate on the slides, and I will reappear at the end of the talk. I have no financial disclosures. So the first development is rethinking about Ewing sarcoma. This is your classic Ewing sarcoma, where you have this monomorphous round cell, small round cell cells with that stain diffusely positive for CD99 with a membranous pattern, and they're also diffusely positive for PAX7 and KX2.2. And sometimes Ewing sarcoma can look a little bit more atypical with more prominent nucleoli and increased nuclei. And this is the classic translocation, EWSR1 Fly1, about 85% of the cases. However, about 10% they have ERG as a partner, or way less frequently they have other ETS genes, other genes of the ETS family. However, we know that in the cutaneous Ewing sarcoma that they behave. First of all, they know we behave better. There are some cases have a very unusual phenotype that says diffuse S100 positivity or SOX10 positivity that have been published in the literature. Actually, we have published two of these cases, and this is a case where we had with this diffuse monomorphous round cells with the pseudoalveolar pattern that were diffusely positive for SOX10, and S100 also showed diffuse membranous positivity, and there were EWSR1 Fly1 fused. And there were a few other reports, very handful of reports. But the new thing is there are 11 cases reported so far. The last couple of years that they reported actually this at least a subset of these tumors that they were called the Ewing sarcoma in the past, and they showed diffuse S100 and SOX10 positivity may actually present a distinct entity named superficial neurocystic tumor. And they had some reproducible morphologic findings. For example, they have this very bland round cells in a triphasic pattern where you have this nest of round cells and the spindle cells infiltrating adipocytes. As you can see here, the cells were diffusely positive for S100 and SOX10, and also some of the cases diffusely positive for NKX2.2. And well, in this paper, they were negative for CD99 and keratin. And CD99 is a very sensitive but not specific immunohistochemical stain for Ewing sarcoma. This was the case which showed EWSR1 Fly1, which actually showed this very hyalinized collagen in between fascicles, and then many tumors have this they were very hemorrhagic, and again this tumor was diffusely positive for S100. Again, this hyalinized hemorrhagic pattern and triphasic pattern with a infiltrative adipose tissue and spindle cells and round cells. There were, as the authors were claiming, characteristic of this tumor, and actually there were new technology was applied, methylation plastering, that's just being used more frequently now in sarcomas, and they were clustered very together and further away, different from the classic Ewing sarcoma, which is further evidence, except apart from the clinical, which they behave very well, immunohistochemical, morphological, that this may be a distinct entity. And then the second paper followed, which expanded on the fusion of the fusions, but they all were FET. They all belong to the FET and ETS family. Some of them were WSR1 Fly1, WSR1 ERG, etc. And as well, and they all cluster with a neurocystic group of the previous paper. Again, kind of show reproducible morphologic findings of these round cells with hyalinized background infiltrating adipose tissue, and all diffusely positive for S100 and SOX10. And some of them show some CD99 confused membrane pattern or non-diffused membranous pattern. And again, another case. So it seems that the EWSR1 Fly1 or the FET ETS in a tumor has diffuse membranous positivity for CD99 or not, and is diffusely positive for S100 and SOX10 in the superficial may not actually represent a genuine, a bona fide Ewing sarcoma by a distinct entity who has a much more indolent behavior. when DFSP isn't really DFSP. So there are tumors out there that they actually resemble DFSP there, but actually then they stain for CD34 and diffuse matter, but they actually do not harbor the classic fusion for the DFSP. And as a matter of fact, some of them they show ALK rearrangement, although the original diagnosis was DFSP or plaque LDP. Uh, um, Plaque-like positive dermofibroma. And there's some examples that we can show here. The spindle cells that infiltrate the fat in a diffuse manner, in a honeycomb manner, and they were positive for CD34, but also positive for ALK. And another tumor, so a bit of whirling pattern. These bland spindle cells, they're also positive for CD34 and ALK, which resembles DFSP and other tumors. So really, if you're not going to molecularly confirm the diagnosis of DFSP, I think it's worth throwing an ALK in case you're dealing with this tumor. And ALK, of course, is a promiscuous gene. This is a classic case of epithelial fibrous histiocytoma with these epithelial cells and the color red. And we know now that the great majority of them have ALK rearrangements, and actually this is being shown in the protein expression level showing diffuse protein positivity. Relatively recently, there was a paper describing a superficial ALK rearranged mixed spindle cell neoplasm that showed this epithelial ovoid cells with a whirling pattern and mixed background and hyalinized collagen. And the authors claim that this could be under the umbrella of the kinase-driven fusion neoplasms. However, very recently, the Boston group showed that actually maybe a continuum between epithelial fibrous histiocytoma and the so-called superficial ALK rearranged mixed spindle cell neoplasm. There are cases that have classic features of EFH and then areas that they resemble what was called initially the superficial ALK rearranged neoplasm. And actually it was pretty interesting because this tumors, they show CD34 positivity and ALK and S100 positivity. And then this was lost in the case that they looked more EFH, but the ALK was positive in both of these tumors. However, the ALK is part of a broader umbrella of kinase fusion, so they can have an expanded clinical and morphological spectrum for low grade to intermediate grade to frankly malignant, but this is more commonly in the deeper counterparts. The superficial CD34 positive fibroblastic tumor was published about a decade ago, and this tumor resembles UPS, but is actually not UPS, has these very pleomorphic cells with a voluminous eosinophilic cytoplasm and in areas infiltrated growth pattern. They look really ugly, but you can't find a single mitosis. The proliferation rate is very low. And this tumor characteristically is diffusely positive for CD34 and can have some desmin positivity, multifocal, focal positivity for cytokeratin. And then they were described as tumors that they were described as low-grade UPS, for example, that they show PDR-DM10 rearrangement, and they look awfully similar. So we now think that this PDR-DM10 genes and the superficial CD34 fibroblastic tumor, they actually belong to the same spectrum. But what is interesting is these tumors show 100% sensitivity for CD34, but CD34 is not a specific marker. But gene expression studies showed that they have a high expression of CADM3, CADM3, which is, we have an immunohistochemistry for that, and actually works very well with almost a very high sensitivity and a specificity. And this is the ultimate paper of superficial CD34 positive fibroblastic tumor from the Boston group that show that more than 95% of the cases stain for this tumor for CAMT3, and actually many of them, about more than 75%, they stain diffusely with a nuclear positivity of WT1, which is a non-specific, but it's kind of unusual for soft tissue tumors to stain diffusely positive for WT1. I told you that it can show multifocal focal rearrangement, but you have to be aware that it can actually, there's a case that showed diffuse positivity for cytokeratin, so you have to be aware that doesn't mean necessarily a sarcomatoid carcinoma or so, and think about doing CD34 because the diffuse expression of CD34 in carcinoma will almost unheard of. But what happened is this discovery prompted them to reassess the so-called atypical fibrous histiocytoma. Now, dermatofibroma had a lot of typical cells, look pretty ugly. So people went back and stained for CD34. And the cases actually with our CD34 positive, they're actually reclassified as a superficial CD34 fibroblastic tumor. Many of them actually show rearrangements for PRDM a gene, and some of them they actually look quite bland, and they're with training collagen bundles at the periphery, or they have these multinuclear giant cells. I guess every time you want to do an atypical fibrous histiocytoma diagnosis, it's worth throwing a CD34. It's diffusely CD34. You actually may be dealing with a superficial fibroblastic tumor instead, which is now a recognized entity in the coming edition of the WHO. Myxoid liposarcoma, it's in the deeper tissues, but it can happen in superficially, and this is a classic. We have these ovoid spindle cells in a myxoid background, very uniform with the chicken wire vasculature, and some of them show different lipoblastic differentiation. And of course, the differential in the superficial sides, it's broad. It can include myxoid DFSP, can call low-grade myxofibrosarcoma, even a myxoid spindle cell lipoma, or myxoid neurofibroma. They're all entities within the differential. But we know now that molecular underpinnings of this tumor, about 97% have FUS DDID3 rearrangement, and 3% have a WSR1 DDID3 rearrangement. And we have a really robust immunohistochemistry now, the DDID3, works extremely well. And it works very well because in the FUS DDID3, or less commonly the AWS DDID3, the whole coding region of DDID3 is retained in the fusion, whereas the N terminal of the FUS and EWSR1 is retained. So the whole coding region, and that's where the antibody hits, and it works extremely well. Even in high-grade myxoid liposarcoma, it was really difficult to be certain that you're dealing with a myxoid liposarcoma or a post-neoadjuvant therapy. And it works really well. Sometimes you can do the DDID3 and the FISH is negative, especially in the EWSR1 DDID3, because you have a cryptic translocation. In this particular scenario, the immunohistochemical stain works extremely well with a very high sensitivity and specificity. And this is a part of a synovial sarcoma, which is rarely can be in superficially, or it can have the tip of the iceberg for a deeper tumor growing up superficially. And this is your characteristic with very monomorphous spindle cells with eosinophilic cytoplasm and inconspicuous nucleoli. Sometimes can have biphasic appearance or monophasic appearance. But sometimes can be really poorly differentiated, resembling basically any poorly differentiated tumor. But we know the molecular underpinnings in this have this translocation involving the X18 genes, involving the SSAT, or formerly SYT, with SSX 1, 2, or 4. And now we have a new antibody, a rapid monoclonal antibody that actually hits the fusion. It's either a fusion-specific antibody who hits the breakpoint or hits the C terminus of the SSX. And it works extremely well, has extremely high sensitivity and specificity. And that actually, in the appropriate morphologic context, can actually actually need the molecular for confirmation. This is very robust antibody with diffuse positivity, even the biphasic or monophasic, even the ones that looks more fibrotic, or the one looks more myxoid, resembling a myxoid neurofibroma. It works pretty robustly, and in the poorly differentiated ones. So this is part of what we call the new generation of immunohistochemical antibodies, next generation immunohistochemistry, which it's based on the molecular underpinnings of the tumors. Cly1 altered mesenchymal neoplasm. This is a tumor. For example, that was sent to me for consultation many years ago from Spain, and it has been called different names, and the last classification was hydroadenocarcinoma. Again, you have these ovoid cells, very monotonous cells with lymphovascular invasion, some necrosis, with this increased vasculature in the background. And this tumor in particular just happened to be Gly1 amplified along with CDK4 and DDID3. They're all in the same, very close in the same area. And that's why this tumor expressed STAT6 and CDK4 and MDM2. Again, this is part of the 12q15 area where these genes are located. And this is the so-called GLI1 altered amplified mesenchymal neoplasm. And the dermatopathology, we're familiar with GLI1, which is part of the Head-Scope signaling pathway, which is so important in basal cell carcinomas. And actually, there's now a GLI1 RNA cytohybridization that can be useful to distinguish this basal cell carcinoma from other non-follicular epithelial neoplasms. And GLI1 altered mesenchymal neoplasm is now a recognized entity, is already a recognized entity in head and neck, and it will be shown in the soft tissue. And shows this multilobularity with this fibrous bands. The cells have some, with this ovoid monomorph monoglomoid cells with this mixed background, and increased vasculature. And it is consistently positive for CD56, or there's not a specific marker, and can show S100 in half of the case. But then it doesn't have a very specific chemical phenotype. And there are genuine reports of genuine cutaneous reports. And we actually published a series of GLI1 amplified mesenchymal neoplasm. And again, you can see here this multilobulated growth pattern with fibrous bands and ovoid cells. This particular case will look a little bit more aggressive. And this was one of the first cases of GLI1. This was another cutaneous case to show GLI1 fusion. Again, this ovoid cells, glomoid, and this got more difficult. But again, you can see the cytomorphology shows this very bland glomoid cells. But how do we kind of diagnose this tumor, which is kind of doesn't have a specific immunophenotype, but actually there is a GLI1 immunohistochemical stain that actually works really well for GLI1 amplified and GLI1 fused neoplasm with a very high sensitivity and specificity. False rearrangements are, we know that the subset of epithelial hemangiomas, they show false rearrangements, and actually these can be explored immunohistochemically by FOS-B or FOS immunohistochemical antibodies, which works relatively well. However, it doesn't have a great specificity. Papillary endothelial hyperplasia or lobular capillary hemangioma can actually show FOS-B or FOS expression. But the new thing is that there is now an epithelial vascular tumor that harbors ALK fusions and kind of resembles epithelial hemangioma. Hemangioma, it could be part of the epithelial hemangioma spectrum or a different entity. And this was one of the first cases reported. Show this case that showed diffuse positivity for ERK CD31 and nicely highlights the pericytes and ALK fusion. And then we got away more cases, and actually this paper was accepted in the American Journal of Surgical Path, and it will be published soon, of a cutaneous hemangioma with epithelial features and harboring ALK fusion, again, nicely here. So every time you have a epithelial hemangioma, a hemangioma with epithelial features, you're not sure what to call it, it's worth trying an ALK. It's reassuring, I mean, because that means there's a fusion-driven neoplasm, so it's almost certainly not an angiosarcoma. Not that the differential was angiosarcoma by morphology, but it's a nice thing. PRAME, clear cell sarcoma, we know it affects usually in deep soft tissues and affect the young patients, but it can happen in subcutaneous tissue and has this diffuse spindle cell proliferation with prominent nucleoli, kind of thinking about melanoma sometimes because it stains like melanoma. But if we have any doubts, we can do molecular studies. We know that clear cell sarcoma has a recurrent translocation of VWSR1 involving ATF1 and less likely CREB1 or CREM. PRAME, we use it all the time in monocytic lesion. And something that is a nice trick is that we know that PRAME is almost always negative for in clear cell sarcomas. And so if you have a tumor that you consider this could be a melanoma clear cell sarcoma, if it's diffusely positive for PRAME, then it's not a clear cell sarcoma. Of course, if it's negative, it could be either. Melanomas are always positive. And the reason this PRAME is consistently negative in clear cell sarcomas is another study, is that we know now PRAME is one of the most underregulated genes in clear cell sarcoma. We know that for a long time for basic science. So it's this very nice, helpful tip. If you consider clear cell sarcoma and the PRAME is strongly diffusely positive, you're not dealing with clear cell sarcoma. PRX NCO182 is a new fibroblastic tumor that is not yet in a WHO, but it will be soon. And all of them are superficial in the subcutis. And this is a case to show an example that show this quite well circumscribed and this fibroblastic cells with collagenous background, quite bland and gapping vessels. And again, this hyalinized background, spindle cells, gapping vessels, uh, and again, with raw collagen bud, it's going to resemble spindle cell hemangioma, and all of them were in the subcutaneous tissue. And there are a few reports out there that some of the cases may actually show some focal, not diffuse S100 or SOX10 positivity, so it can actually be confused that with a neurogenic tumor. They're not, and they're never diffusely positive, diffusely and strongly positive. And actually, some of them can actually show a pigment, actually show pigmentation. So you have to be aware of that. And it's not a surprise that you have a fibroblastic tumor with a PRX1 gene because this is the master transcription factor um, in the transition from fibroblast to a myofibroblastic phenotype. And lastly, CIC rearranged round cell sarcomas are part of the round cell sarcomas of the non-Ewing, the most common non-Ewing round cell sarcoma, and most of them have CIC DAX4 or the homolog DAX4L partner. And there are genuine reports in the subcutaneous tissue. We report some of them. You can see these round cells that some myxoid background. Sometimes it can be a little bit spindly. And this, we know that they have upregulation of WT1 and ETV4, and these stains can actually be helpful in making the diagnosis. When you use molecular, you have to be a little bit careful because 50% actually have cryptic rearrangements, so they're negative for FISH, and sometimes you have positive FISH and negative NGS because they're not detected automatically by the software. However, there's a very reliable now DAX4 immunohistochemical stain, which we know it was an older paper that had 100% sensitivity and didn't stain any entities in the differential. But now there was a new paper that actually has extremely high sensitivity and pretty high specificity of in CIC round cell sarcoma. So very nice, crispy nuclear stain. And of course, we're going to work in a CIC DAX4, which is the great majority. But if you have a different partner like FOXO4 or other partners that actually we described, this immunohistochemical antibody obviously is not going to work. And before you call it, but even if it works, before you call it sarcoma, you have to make sure you're not dealing with the different lineage because DAX4 are happening in lymphoblastic leukemia, for example, or rhabdomyosarcomas. If this is a rhabdomyosarcoma, this is a very old paper. But in any case, the specificity is not 100%, so you have to be sure you're dealing with a round cell sarcoma. But you have to be aware that CIC rearranged sarcoma, they can express ERG, they can express MYC, and actually they can express CD31 as well. So you may have a tumor CD31 positive, ERG positive, MYC positive, and you may want to call it angiosarcoma. You would be wrong because these are genuine CIC rearranged sarcoma, where the true angiosarcomas, they don't have expression of ETV4, and they don't have nuclear expression of WT1, and obviously they're going to be DAX4 negative. And as part of the AUC committee of the American Society of Dermatopathology, we actually analyzed the whole literature, and this is the most recent publication, very recent publication last month, comprehensive review of the ancillary tools for the diagnosis of CIC rearranged sarcoma. This is my email, my Twitter account, and my YouTube. If you want to subscribe to my channel, I will put lectures for educational purposes. And I'd like to thank you very much for your consideration. And if you have any questions and stuff, you can send me an email or you can subscribe to my channel and make a comment there, whatever is convenient for you. And with that, I would like to thank you and have a great evening.